So, speaking after two high voltage presentations of Dr. Devashish Chaudhary and P.N. Saileja, I have no choice. Well, thanks to Dr. Garg and Dr. Dubey for inviting me. So, when he asked me to talk on this topic, I went to ChatGPT and asked these questions. Hi, ChatGPT. Dr. Arun Garg asked me to give a talk on AI in ischemic stroke. Can you prepare a PowerPoint slide for me? And interestingly, it came up with a slide set with some outlines. And that did hurt my ego. I thought I can do better. So here we are. So I don't know the technology of AI. It's complex. We are not an expert in that. But all we know, this is a subfield of computer science aiming at emulating the human cognitive process. So our brain, they go by this, this paradigm that data, information, knowledge, and wisdom. This is how the thing get refined at every level when it go up the pyramid. And the AI technology also get the concept from here, when from the data, it refines with the refinement of technology and go up. So here comes the importance of AI. Why we need AI? Because now we have data in the world. And this is the amount of data we have in this world at this moment. It's 147 zettabyte. And 1 zettabyte is 1 trillion gigabyte. So healthcare is no exception. Why there is a auto? I'm not doing anything. Anyway. Okay, yeah, I understand that. So healthcare is not an exception. So we need help of this technology to deal with a huge amount of data in healthcare as well. So this is how the AI evolved over the time. There are the three epochs of AI which actually started long back. It started from a very symbolic AI to the machine learning and deep learning, and eventually the generative AI. And this ChatGPT is actually a very good example of generative AI, where it can create synthetic data. And it also can have some behavioral modulations. If you look at the ChatGPT 3, it used 170 billion parameters. And that can actually modify a lot of behavioral changes in the output. And ChatGPT 4, we do not know how many parameters they actually used. It may be trillions. So this is actually now coming under the purview of a general purpose technology. What is a GPT or general purpose technology? It's a technology which has developed for a purpose and now being used in many different purposes. For example, electricity. We invented electricity. And now see, electricity is being used everywhere in this world. So AI is also a technology which will be used in different walks of life for our purpose. And this AI, especially the artificial neural network which is being used in the deep learning process, which also emulates our human brain. When there is an input layer where informations are fed, for example, your brain imaging, then it goes to a hidden layer, which is actually the processing part of our brain, where it processes all the informations and comes out with an output layer, which gives you the refined information for our purpose. So why AI in stroke? Because stroke is one of the medical subspecialties which adapted AI pretty early. And we know time is brain. So in an ischemic stroke particularly, in the first few hours, we need a lot of parallel processing very fast, starting from the patient assessment to the imaging and preparing your team. So if this processing made faster using the technology, so we can minimize our time to treatment gap. So this is how AI comes handy. And dawn and diffuse trial particularly, when they used a new imaging paradigm, then the use of AI came into practice more and more because we need a lot of information about the imaging in a very short period of time. So what we need to know about stroke when we use AI or when you use our interpretation, is this a stroke, ischemic or hemorrhagic? If there is a stroke, what is the severity of the stroke, like aspect scoring? Is there an LVO? If the patient is a candidate for thrombectomy, and will the patient be benefited from the therapy? I think these are the very basic questions we ask ourselves, and we might take the help of AI. Question is how much help we are currently getting. So these are the different AI platforms are being used at different parts of the world. Rapid AI is probably being used in some centers in India. I also use Rapid AI, though I don't find that very, very useful for my purpose, but it's good for the residents. And you can see most of them actually use CT and CT NGOs. Some use MRI though, but they come up with a very nice image of a non-con CT, aspect imaging, LVO detection, perfusion imaging, and the mismatch. So the current workflow at this moment using all these platforms, patients come to the ER, goes to the imaging suite, get the CT, CTA plus minus CTP, image is processed, including the collateral informations, and that is directly fed to the mobile app of all the people in the team, the stakeholders. There is a stroke and there is an LVO. So inform the radiology guy, intervention guy, prepare the team, and go for the therapy. But there are limitations. The limitations are there might be some noise, because if the data fed at the baseline are not very refined and good quality of data, it cannot differentiate between the noise, and over-interpretation is always a problem. So I will walk you through the current evidence very briefly to see how we are doing at this moment. You know that automated aspect scoring, the E aspects, are being used by almost all the platforms. The Calgary group looked at it very carefully and compared with the DWI aspects. And they find that they have a good specificity, but sensitivity is pretty low. But this Japanese group, they are always technologically very sound. So they use this Canon medical device, and they claim that it can be comparable with a board-certified vascular neurologist. I don't know whether that is really true, but they can be useful in some cases. But the paper from Edinburgh group, Joanna Wardlow, they looked at the external validation of E aspects and found that there is a 10% failure rate in the software processing. So they put a very strong cautionary note that they should only be used as indicated to assist an experienced reader and should not be used as a standalone diagnostic tool. Similarly, CT angio, it can get an accuracy to detect a disease, LVO or other things by 70 to 75%. If you look at the LVO detection, that can improve a little better in the tune of 90%, and of course the collaterals. But the collateral assessment using deep learning still cannot do as good as an experienced and trained eye. This paper is actually a little bit different, and it brings out a more practical aspect of the whole thing, where a large data set from a registry, not from the trial, from a real life registry, can be helpful to include all kinds of patients which are not actually trial patients, to understand their prognosis when we applying a treatment. So this is what the current evidences are talking about. So coming to the practice again, these are all actually non-randomized data, but still AI cannot reach the specificity of human being, which is 57% compared to 84% in the human being. The only big randomized data currently we have is the Golden Bridge 2 trial. It's a Chinese trial, a big trial, recently presented in ISC 2024, looked at 20,000 patients. And they divided the patients, it's a cluster randomized trial, divided the patients into two groups. One is the AI clinical decision support system group and another conventional group. And they looked at the composite vascular outcome. and there is a 1% absolute risk reduction. I don't find that is a very robust, but there is 1% absolute risk reduction in the composite vascular outcome. But there is no significant difference in the big stroke where the MRS is between 3 to 6 at 3 months. So again, despite all this technological advancement, we're still not there. So are we really going through a hype cycle where there is initial hype for anything new, a new star, a new political leader, or news item, song like this, and then goes down? So time will tell us. But governments have picked up it seriously. Our government also picked up AI. They formed their new site and new approach to AI. And NEJM also published a new publication of NEJM AI. This is a new journal. You can see interesting articles there. But the most important thing which I will finish my talk today is the accountability and the AI law. This is where everyone is silent. I spoke to many of my lawyer friends, and they are clueless. And this is same all over the world. Who is accountable? Who will be accountable for AI failure? And there is no straight answer to that. So I will try to answer that question through this movie clip. I do not know whether you have watched it. This is a movie where Denzel Washington was a pilot. So his plane came under a severe turbulence. One engine got damaged. So with some heroic maneuver, he managed to crash land the plane, saving many lives with only 6 deaths. And he was subjected to investigation. So if we can play this. I hope the sound is there.
Pleasure to meet you, Captain. My pleasure. Sit down. Want a coffee? Yes, I do. Give me some fresh coffee. We were just talking about your co-pilot's wife. Told the newspaper that God landed at night. Yeah? Oh, God landed What's that? As you know, when a plane goes down, the NTSB sends a go team to address. I mean, they find the flight data report. They did. It's perfectly intact. Great. So, why do we need a lawyer from Chicago? Well, he specializes in criminal negligence. Criminal negligence?
Death demands responsibility. 6 dead on that plane. Someone has to pay.
Yeah, but there's a plane that fell apart at, I think it fell apart at 30,000 feet. And the airline will try to prove equipment failure, which is going to make the manufacturer responsible. The manufacturer, in turn, is going to try and prove poor maintenance of the equipment by the airline.
Or pilot error.
Attorney from Chicago.
So all boils down to pilot errors. So the buck stops here. So we are still responsible, whatever AI you use at this moment of time. Thank you very much. So I do not know whether it did better than ChatGPT. Thank you.